Massage therapists know better than anyone the healing benefits of bodywork are not just for a lucky few. Rather, massage is for every body. ABMP's Massage is for Everybody Week, celebrated July 19th through 25th, is part of a bigger year-long movement grounded in advocacy, awareness, and inclusion. Join ABMP in celebrating the powerful benefits of massage and the meaningful role you play in your community. Together, we're helping to expand access, support underserved populations, and elevate the profession with compassion and professionalism. Learn more at abmp.com/massage-week. At Heights Retreats, massage therapists build stable and meaningful careers rooted in wellness and care. A place where therapists are dedicated to delivering exceptional care to the guests, not to filling their schedule. Heights Retreats care deeply about their therapists, our profession, and wellness itself. Grow with Heights as they evolve into a wellness-driven future. Visit heightswellnessretreat.com for more information.
When I was a newbie therapist, I had a client who was one of my first regulars. He was a really nice guy. He was a realtor, and he liked to chat while I worked. I didn't have the boundaries set up yet to limit his chatting, but I also welcomed it. I was still nervous and secure and trapped in my own needs to be liked, and I think he was a little too. Among many other things, he talked a lot about his new girlfriend. They had just met, and he wanted so badly to impress her. It's funny now in hindsight, but we were a bit of an awkward pairing, me wanting to impress him and him wanting to impress her. Anyway, he bought her a gift certificate to come see me, which I used to get really nervous about because I knew, even in my adolescent career, that just because one person liked my work didn't mean that everyone would. Still, she booked the appointment, and there we were. I don't remember her name or much else about that day, but the session itself sticks with me. Because I know now that I didn't know what I know now, you know? As I started the work with her, I pulled out the usual game plan. I chatted with her a bit before we got started, had her get comfortable face down on the table, and I began the session with the usual effleurage down her back, from her neck through her shoulders, down her paraspinals, and into the hips. I noticed, but I didn't give it much thought, that her skin had a little more slack than I was used to. Whatever, everyone is different. I continued with the session and realized that it was more than just a little slack. Her skin was loose. It was so loose that it was almost too difficult to get into the tissue underneath the skin. I was struggling to work into her actual muscles, and when I was able to sink into the muscle tissue, she complained of feeling generally tender, mostly everywhere. I knew she hadn't lost a lot of weight recently, and I knew she didn't work out. So I figured in my young therapist brain that she was just more sensitive than most and that she had amazing connective tissue. It was awesome. Healthy, hydrated, the polar opposite of adhered. And I was so convinced that I complimented her on it. I literally told her how impressed I was with her connective tissue. She was a bit baffled by this observation, understandably. What kind of a compliment is that? But I, on the other hand, was so impressed with myself. I knew stuff, and I was being very smart, and I was a very cool massage therapist. Fast forward 25 years and a lot of humility later, I know a couple more details about human anatomy than I used to. She, I'm pretty sure, had Ehlers-Danlos syndrome. Probably she still has it, I wouldn't know. She never booked another session with me, and neither did her boyfriend. That's okay, though. I'm a firm believer that the only thing we really know is what we experience. And I hold this close to my core as a massage therapist. For example, I know everything there is to know about ACL tears. I have one. I know what it feels like. I know what it means when it's not rehabbed well. I might be guilty of that. And I know what living with a surgery that was groundbreaking in 1985 means for mobility in 2026. And while I have never been diagnosed with Ehlers-Danlos syndrome, or EDS for short, my experience with that client taught me a lot. Mostly, it taught me that there will always be stuff I don't know. But also, it taught me about EDS. Clearly, we can't have all the dysfunctions and know everything about all of them from personal experience, but sometimes experiencing even the adjacent rejection of having misstepped as a therapist is enough. It has to be. So today, we are diving down the Ehlers-Danlos syndrome rabbit hole. EDS is a group of heritable, meaning they are mostly hereditary but can also occur spontaneously, connective tissue disorders. And when I say connective tissue, I mean all of it. Skin, joints, blood vessels, organs, the fascia wrapped around every muscle belly, the ligaments holding every joint together, the walls of your digestive tract, the tissue anchoring your eyeballs. Connective tissue is, in the most literal sense, the stuff that holds a human being together. And in EDS, it is compromised at the collagen level, specifically in how collagen is synthesized, structured, and maintained. There is essentially a genetic fault in the raw material of the body. There are 13 recognized subtypes of EDS. Yes, 13. A fact I didn't know before diving into the research for this episode, each with their own genetic baseline, presentation, and level of clinical alarm. The Ehlers-Danlos Society's 2017 International Classification maps out the current framework, and I'm not going to detail all of them here today. They also have many informative videos on YouTube. I highly recommend checking them out. For now, though, I will highlight the big ones. The subtype you're most likely to encounter in your practice is hypermobile EDS, or little h capital EDS. It is the most common by a significant margin. The hallmarks are generalized joint hypermobility, along with soft, velvety skin, chronic pain, easy bruising, and recurrent joint subluxations or dislocations. What makes HEDS especially interesting is that it's the only subtype with a genetic marker. So there's no blood test or biomarker. The diagnosis is purely clinical, which means it's dependent on the quality of the clinician doing the diagnosing. Classical EDS, or little c, capital EDS, presents with extremely elastic and fragile skin, wide indented or depressed scarring called atrophic scarring, and joint hypermobility. Kyphoscoliotic EDS involves a progressive spinal curvature, muscle hypotonia, and ocular fragility, or a general weakness to the eyeball's structural tissues. This one tends to present in infancy or early childhood. Arthrochalasia EDS, arthro meaning joint, and chalasis meaning a loosening, relaxing, or slackening, is characterized by severe generalized joint hypermobility and congenital hip dislocations. And then there is vascular EDS, or little v capital EDS, which is the one that carries a genuine life-threatening risk. In VDS, the fragility extends to the arterial walls and visceral organs, meaning the chances of spontaneous rupture of a major blood vessel or an organ is real. This is, as you can imagine, a big old contradiction for massage therapy. But beyond the joints and the skin, EDS is increasingly understood as a systemic condition, meaning it reaches into territory that most people would never connect to a connective tissue disorder. They do say, if you can't connect the issues, think connective tissues. Dysautonomia, particularly postural orthostatic tachycardia syndrome, or POTS, is a common comorbidity, or a dysfunction that often shows up alongside of EDS, but not necessarily as an EDS symptom per se. The autonomic nervous system struggles to regulate itself in the absence of stable connective tissue support around the vessels. Other comorbidities include mast cell activation syndrome, or MCAS, impaired gastrointestinal motility, chronic migraines, proprioceptive deficits, and, of course, fatigue. On top of all of that, many people with EDS also live with anxiety, depression, and cognitive fog. There is a genuine debate in the research about how much of that is neurological, how much is the chronic psychological toll of living in a body that hurts and doesn't behave predictably, and how much is the inevitable result of spending years being told that nothing is wrong. Which brings me to what I believe is the most important aspect of EDS to note as a bodyworker. On average, it takes about 10 years and 15 different clinicians for someone with hypermobile EDS to receive a confirmed diagnosis. In a survey of over 500 people with confirmed HEDS, the average number of alternative diagnoses they received before getting the right one was more than 10. Anxiety, depression, and migraines were among the most common of those, which, if you think about it, makes a terrible kind of sense. If every provider you see tells you that your symptoms aren't real, you are most likely going to develop anxiety and/or depression, and your nervous system, in turn, is going to begin to believe it. And then someone will write that down in your chart as though it explains everything. EDS patients are sometimes referred for psychiatric evaluation, told it's all in their head, and classified as somaticizers, or someone who expresses psychological distress as physical symptoms. And because HEDS disproportionately affects women, ranging anywhere from a 7-to-1 to a 10-to-1 ratio for women to men, we are looking at a condition where gender bias in medicine is baked directly into the diagnostic delay. So by the time someone with EDS finds their way into your office, they have likely spent years being dismissed, misread, or straight up disbelieved. They may have more clinical knowledge about their own condition than many of the practitioners they've seen, and they are often exhausted in a way that goes far beyond their physical symptoms. This is where we come in. Not to fix them, of course, but to be a space where their body and their feelings are listened to without an agenda. Because what we need to understand about EDS and bodywork is that we cannot change the underlying pathology. We are not going to strengthen the ligaments. We're not going to remodel the collagen. We're not going to tighten up the joints like we have some sort of anatomical screwdriver. The connective tissue laxity is structural and genetic. So whatever tissue integrity has been compromised, the internal supports, the visceral ligaments, the vascular walls, those are not within our scope to rebuild, and they never will be. What we can do is meaningfully help manage pain and stress. For someone with EDS, those two processes are often the loudest and most relentless voices. The nervous system in EDS is chronically dysregulated, which amplifies pain signals. The body works overtime to stabilize joints that can't hold themselves, which means the muscles surrounding hypermobile joints are often in a constant guarding state. They're not tight because they're strong. They're tight because they're hanging on for dear life. There's a difference. And working with that tissue slowly and attentively, without aggressive force, can provide genuine relief. The clinical guidelines here are not complicated, though they do require you to check some instincts at the door. No aggressive stretching. These joints already move farther than they should, so pushing range of motion is not a goal. No deep digging into trigger points, no scraping, no fascial work that relies on sustained compressive force. Joint mobilization is not your friend here. What is? Slow, supported, moderate pressure. Check-ins, communication, and letting the client lead. These clients know their bodies with a specificity that many people never develop because they've had no choice but to pay very close attention. And maybe most importantly, hold space for the emotional weight they are carrying. Because the research is clear that by the time someone with EDS is sitting in front of you, they have likely fought for their diagnosis, grieved for the version of themselves that didn't have it, and learned to navigate a world that was not designed for the kind of fragility that they live with. Your table might be one of the very few places where someone touches their body and asks how it feels, rather than assuming they already know. That is not a small thing. I've been doing this work for more than 25 years, and I still think about my first regular client and his girlfriend, whose skin told me something I wasn't equipped to hear yet. I didn't have the vocabulary, I didn't have the education, and I genuinely thought I was giving her a compliment. And while I can't go back and fix that session, I can carry what I didn't know then into every session I have now.
Precision Neuromuscular Therapy has been teaching high-quality seminars for over 20 years across the country. Founded by Doug Nelson, PNMT uses problem-solving skills and precise treatment options to get powerful results for your clients. PNMT seminars focus on honing your assessment and palpation skills to precisely target the source of your client's pain while understanding the why behind the what. Meet us in a hands-on seminar or online in the PNMT portal and let us join you on your learning journey. Learn more at pnmt.org. Elevate your bodywork career with Anatomy Train's Structural Integration Certification, ATSI. Discover how to map the pattern and shape the change through inspiring lectures, hands-on body reading, and practical techniques you can use in your practice right away. Join us for ATSI Maine 2026 to 2027, where Tom Myers will personally kick off this transformative professional training. Learn more at anatomytrains.com/ATSI.